There are a number of reasons when a patient has pancreatic cancer that they might get pain. First, the tumour itself. The tumour can invade into nerves, particularly the celiac nerve, which runs behind the back of the pancreas, and that's why we get those classic pain over the stomach that can go through to the back and therefore can be sometimes misdiagnosed. But pain can be a little bit more non-specific, and it can feel a little bit like reflux, it can feel a little bit bloated. Constipation is common, both from the tumour as well as some of the therapies that we can use, but also where the pancreas sits is the outflow of the stomach, so it can slow the emptying of the stomach. So a lot of pain can be related to slowly emptying food or reflux. So it's really important to try and drill down and decide, is the pain related to the tumour itself, and we need to manage the tumour, or is it a result? And we can use other therapies to try and manage that better.
It's really useful to track your pain symptoms, especially if you can record them for your doctor to see when they see you every other week or so. And the best way to do that is to have a pain diary, really, where you record your pain on a scale of 1 to 10 and present it to your doctor so that they're able to establish if you're on the right pain regime and right pain relief or not. For example, if you're reporting having pain more than 3 to 4 times a day, it may be that your pain control is not adequate and your doctor may think about increasing your pain medication.
For management of pancreatic cancer pain, the mainstay of treatment is obviously analgesia, and most of that analgesia in care of cancer is narcotic. But because a lot of the pain related to pancreatic cancer is a nerve pain and often related to infiltration of the nerves that supply the pancreas, particularly the celiac, then we often also use nerve drugs. So drugs such as neuroleptics, so drugs that dampen down nerve endings, can be very, very effective. Now, if tablets and simple analgesia is not effective, then we can move on to other strategies. The celiac axis runs behind the back of the pancreas and supplies the majority of the gland. What we can do is actually block that nerve via endoscopic ultrasound. So if we just sit an ultrasound probe in the very top of the stomach, we can actually see the plexus or origins of these nerves, put a needle into this plexus, all under ultrasound's vision, so very, very safe, and actually inject lignocaine and inject ethanol to ablate the nerve, and that has been shown to be highly effective in managing pancreatic cancer. The final way of managing pancreatic cancer pain is radiation therapy, and again, this can be useful. That can take a few weeks to have an effect, so often we need to use other things in the meantime while we're waiting for it, but again can be very, very effective, and speaking to an oncologist about options here is the best way to do things.